Essentially, I will try to, in discussing modality of renal replacement therapy, try to put yourselves in the situation of dealing with it and helping me try to design what kind of treatment we will apply. Understanding that in acute kidney injury, renal replacement therapy is a multidimensional task that has to do with how we apply the technology, but also the patient plays a significant role, as well as the institution and a series of limitations. This is a multi-component problem in which not only the very complicated situation of the patient with his multiple organ failure, acute kidney injury, and comorbidities contribute to the outcome, but also all sorts of modalities and different ways of modalities and solutions and buffers that we can choose or not to choose have a significant impact in outcome, as well as necessarily what is the situation in the institution where this occurs. There are institutions where you can get away and do CRRT, other institutions when you do plasma filtration and hemabsorption, and other institutions in which all you can do is intermittent hemodialysis. And so far, let me just say from now, in terms of modality, we have been unable to show a significant difference. And I will leave it at that because I will not review studies that have been reviewed previously. The fact is that the combination of the patient conditions, the situation in the institution, as well as the modalities, hopefully, that we apply, contribute to timing and the delivery of an appropriate or an inappropriate dose, the recovery of function, survival, and hemodynamic stability. So outcomes are the result of a very complicated interaction of things, and among which modality is one of the components. So this gives you an idea how difficult it will ever be to demonstrate that in this multi-compartment situation, this modality or this other modality will have more or less of an impact. The other issue, too, is that when we look at the outcomes, we should emphasize not only the fact that some patients survive, but also, like Sean was emphasizing, the fact that recovery varies and that perhaps timing and the modality of dialysis have something to do on recovery of function, which is an extremely desirable and an extremely important consequence, as well as the issue of the onset of new lesions that may lead to chronic kidney disease and ESRD. The other point that I wanted to make in commenting beautiful Sean's presentation is that we are currently trying to incorporate acute kidney injury within the global burden of disease. We have chronic kidney disease incorporated, and we're trying to incorporate acute kidney injury through the 0/25 initiative. And the point that we're trying to make is that acute kidney injury, which is associated with mortality, right? Probably the mortality associated with acute kidney injury is not intrinsically due to acute kidney injury, but rather acute kidney injury may play an intermediate role between sepsis and death. Acute heart failure and death, or acute respiratory failure and death. So that makes it even more difficult to tease out what are the factors that lead to mortality, and in that sense, looking at recovery may be a better alternative. So the characteristics of the ideal acute kidney injury treatment were well defined by Norbert many years ago, and I think that we're striving to achieve those components. But in essence, when each one of us tries to decide what modality of dialysis one is going to apply, the decision, which to us appears very simple, is actually very complex. If you think of it, all of you not only think in terms of modality, and within modality, if you're going to do it every other day, daily or SLED, or continuous or peritoneal dialysis, but also we need to think of the membrane characteristics, dialysis biocompatibility, the efficiency, the flux, the timing, etc. And I will try to address some of those points. The other issue, too, that I will not discuss because there is consensus, even though there is no randomized control trial that supports it, is that when one looks at the hemodynamics of the patient, the consensus is that patients who are hemodynamically unstable are better treated with continuous modalities versus those who are hemodynamically stable, which can do well with intermittent modalities, except in the situation when brain edema occurs, in which, as we know, it is essential the use of continuous renal replacement of the modalities so that we don't worsen the degree of brain edema, especially in fulminant liver failure. The other issue, too, is that even when we talk about continuous renal replacement therapies, we need to be careful, because it is one thing to talk about CVVH, another thing to talk about CVVH-D, another thing to talk about CVVH-DF, but when we start doing plasma filtration and adding an adsorbent and do plasma filtration and absorption, how do we compare the outcomes of this very complicated technology with regular CVVH? So I think that the complexity of the field is such that we have a hard time making a decision. So we're about to make the decision, and we're about to treat the patient. Professor Ioannidis is going to discuss anticoagulation. I will not go there, except to make 2 points. One is that I'm among those who believe that anticoagulation should be used most of the time instead of rarely, like Dr. Osterman showed us before. And my bias would be that once you start using citrate, you wonder why you would not use anything other than that. Multiple machines are being used, and most of my presentation then will focus on the recent efforts that we have been doing in collaboration with Claudio and many others that are in this audience and in this list, especially Mauro Neri, Gianluca Villa, and Francesco Garzotto, that have collaborated very strongly in developing 2 papers that have been submitted that we hope will be published very soon on nomenclature for renal replacement therapy in acute kidney injury, both basic principles and practical applications. I will be going quickly over the calculations. You're very welcome to have all my slides because I will not be able to go into details. As you know, in terms of transport mechanisms, we can use for fluid transport ultrafiltration, but when it comes to solute transport, we either use diffusion, convection, or absorption. In ultrafiltration, is the movement through a fluid membrane. In general, in diffusion, it's best for small molecular clearance as well as when we use convection. It is mostly effective for removal of larger molecules, and because it is less dependent on molecular size. So in diffusion, the main issue is that we use the random passage of the solute across the membrane, and that is determined by the fixed law of diffusion, in which the key issue is the diffusivity coefficient. And the only point to make at this point is that when one makes that calculation, one needs to emphasize that the radius of the molecule, the effective radius of the molecule, is the defining issue on the magnitude of diffusion, and therefore the larger the molecule, the lesser the diffusion. So in diffusion, the size of the molecule is an extremely important component. Conversely, in convection, the key element is the ratio of the specific solute concentration in the ultrafiltrate to pre- and post-filter solute concentration, which is called the sieving coefficient. Let me remind you that the sieving coefficient is applied to convective transport, but not applied to diffusive transport. And that the flow, the convective flow, is dependent upon the magnitude of the ultrafiltration, the area, and the sieving coefficient, as you know. Instead, in the case of absorption, most of the molecules are attached to the membrane. This diffusion of molecules or the convection of molecules across the membrane is also determined by the cutoff point, and you have heard cutoff mentioned many times already during the previous sessions, in that essentially solutes either in hemofiltration, natural kidney function, or hemodialysis are defined by the cutoff point, which is the molecular weight of the smallest solute retained by the membrane, in this case about 0.1. So, but in essence, to define what the membrane behaves like, one needs to know not only the cutoff at 0.1%, but also at 0.9, so one knows what the profile of molecules that will be transported is like. In ultrafiltration, the main issue is the reduction of fluid across the membrane. That is dependent upon the membrane ultrafiltration coefficient, and that filter ultrafiltration coefficient, that is a consequence of that, as well as the area of the membrane. It is also important to remember, though, that when we think of the interplay of pressures within the filter, we're actually oversimplifying, and that many other components have to do with what happens across this membrane, because it's the interplay between the pressure of the blood, the pressure in the dialysate, as well as the continuous increase in the oncotic pressure along the filter, that makes that the effective transmembrane pressure along the filter diminishes progressively to the point that at some point in the length of the filter, there actually can occur backfiltration, which has important implications in terms of the clearance by this filter. Mostly, the machines give us a transmembrane pressure that is the result of the difference between the pre and the post-filter pressures, but in essence, let me remind you that that transmembrane pressure is inaccurate because other issues like the change in oncotic pressure that is not measured by the machine also plays a significant role. In hemofiltration, as you know, veno-venous hemofiltration, the main issue is convective transport, and in this sense, as we transport convectively across the membrane, we either replenish the fluid pre-filter or post-filter. And if we, depending on which one of the two alternatives we choose, the consequences in terms of the clearance achieved will vary. On the other hand, when we use hemodialysis, the main way in which the clearance occurs is by diffusion, by passive diffusion, according to the equations that I showed you earlier. But remember that when we look at intermittent hemodialysis, the magnitude of the dialysate flow is enormously larger than the magnitude of the flow in continuous hemodialysis. And therefore, we go from 500 to 800 ml per minute in hemodialysis versus 17 to 30 to 50 ml per minute in continuous VV hemodialysis. And therefore, even though in both cases we're using diffusive technologies, in this condition, given the very rapid and very powerful clearance by diffusion, this causes all sorts of osmotic shifts across membranes, which do not occur in this case, in the case of CVVH-D, not because of the diffusion, but because of the small or the slow rate of correction. In CVVH-DF, we have the combination of the two, and usually in this situation, blood flow rate is about 200 ml per minute. And let me remind you that while we have been used to using heparin, and we tend to think that when using heparin, the faster the blood flow, the better, actually when one is using citrate, generally the blood flow tends to be much slower, and the slower the better, because it gives a chance for the ionized calcium to remain low and avoid the coagulation. The other issue, too, is that the magnitude of the ultrafiltration can be thought of in two ways. A lot of some colleagues who don't quite understand what continuous renal replacement therapy is all about tend to establish the magnitude of the ultrafiltration in terms of 24 hours, right? They establish the goal. What is your goal? 2 liters. And that, I think, is an imperfect use of what is otherwise a very beautiful way of managing fluids. Is much, much better, I think, to set up hourly desired patient fluid management so that, for instance, if you have a 24-hour protocol and you're trying to remove 1 liter a day, either you can do the calculation of what is going in and divide that by 24 hours and you remove 50 ml per liter. But the reality is that that patient may have had an output through the NG tube of 8 mLs, an input for this transfusion of 216, a desired fluid hour loss is 100 ml an hour. So actually, if you calculate the necessary net fluid removal for the next hour, you have the beauty of being able to adjust continuously the magnitude depending on each hour, on the preceding hour, and you utilize this device as a fluid control device much better than just ultrafiltration. The other issue to remember, though, is the magnitude of the ultrafiltration has an impact on the filtration fraction, which is a measure of how much the plasma entering the fluid is concentrated by ultrafiltration. Necessarily, if you filter water, less water comes out of the filter than the water that enters the filter. That concentration of the plasma raises the concentration or the number of the density of red blood cells and therefore enhances the clotting. So you're in charge now, because we went over all the formulas that you needed, and now you know them very well. So get your calculators because you're the doctor. And the point here is that, unfortunately, at least in the US, one of the problems that we're running into, Ashita and I, in our efforts to teach CRRT, is that the doctors, the fellows, rarely, except in UAB, the fellows don't touch the machine. And they ask increasingly for CRRT per protocol. Right? So the idea would be that it is necessary to understand the machine, it's necessary to touch the machine, and it is necessary to know where the lines go in and out, and that requires some calculation. So here you are, 44-year-old male, baseline creatinine 1.2 with a history of B-cell lymphoma, started on chemotherapy, develops tumor lysis syndrome, septic shock, and acute kidney injury. The admission weight is 100 kilos, which we will use as a dry weight. And these are the labs when we're called. As you can see, we're called very early to see the patient, right? Creatinine of 5.6, the BUN of 54, and a critical potassium of 6.4. Ravi and Sean would agree that we should initiate some kind of dialysis. Liver function is normal. The fellow last night started the patient on CRRT. So this is the situation. The patient is on CVVH, a very popular way of doing CRRT. The blood flow rate is 200. The ultrafiltration rate is 0 for the sake of simplicity. Replacement fluid is going at 220 ml an hour, 2,000 pre and 200 post-filter, and the anticoagulation is with citrate. Okay. The fellow did a lot of good things. He used a protocol, that's good. He put the patient on anticoagulation with citrate, which prevented clotting. But the following morning, these are the labs. The sodium is 132, the potassium is 6.8, and the chloride is 98. The bicarbonate hasn't gotten much better. The BUN is 56, the creatinine 4.8. What is happening to the patient? So we need to make some adjustments here because he thought that he was doing something good. So the first thing that you need to do is to review the prescription and to talk with the nurse and to talk with everybody, right? So you ask how many times did the patient go to the OR and how many hours was the system down? How many times did the system clot? How many CT scans were done, etc. Because something is going on with the dose, right? You're not clearing appropriately, even though the prescription appears good. So there is a prescribed dose, but we need to calculate the delivered dose and what is the composition of the replacement fluid and the dialysis fluid and what changes would you like to make. So if we calculate the prescribed dose, since we're using simple CVVH, the effluent flow rate, which is the replacement fluid plus the ultrafiltration, in this case ultrafiltration is 0, so the dose is equal to the replacement fluid. So the recommended dose, as you know, is 20 to 25. But to achieve that, you need to give more because there is a very clear correlation between survival and dose. As long as we do too little or too much, probably this is inadequate. In too little area because we are underdosing the patient. In too much dose because, like Sean was saying, we're removing things that we don't want to, like antibiotics and pressors. But then there is a practice-dependent region, and within that practice-dependent region, a lot of factors have an impact on what is actually delivered and what is actually happening that have to do with the operation characteristics, the timing, the hemodynamics, the patient characteristics, and the pharmacology. Remember that you're not just done when you prescribe, but actually you need to look at the patient, you need to look at the machine, you need to talk with the nurses. And one of the factors that you're suspecting is happening here is that the dose that is being delivered is less than the dose that was prescribed because we're diluting that filter, and therefore that diminishes the dose. And I won't bother you with the details of the dilution factor, but again, you're more than welcome to share my slides, and definitely I want to encourage you to read those two papers that will have all the details. Essentially, the dilution factor allows you to measure or to estimate how much dilution will be there of the plasma, so that will diminish the dose of dialysis. So we go back to the patient. Was there treatment downtime? You need to talk with the patient, you need to talk with the nurse, you need to touch the screen. This is all there, so if you touch it, there's no mystery. What is the prescribed dose? The calculated dose is 22 ml per kilo per hour, sort of okay. Perhaps I would have gone up higher, but let's say within the range. But is that in the machine? Yes, it is in the machine. It is in the screen. It says what the dose is, so touch it again. And what is the delivered dose? And this requires some paper and pencil, but if you calculate that, you end up, because of the dilution, down to 17.6. So now you're underdosing the patient, even though the things seem to be moving around, and this is your responsibility, because if you don't make the calculation, it won't happen. And the replacement fluid contains too much potassium, and perhaps you want to change that. So we changed the prescription, and this is a new prescription. Now, let's say that because our problem was dilution, and we don't want to use so much pre-filter replacement fluid, we may want to use it post-filter, so let's do that. And now we have, as you can see, 2,500 post-filter and only 200 pre-filter. And now if I made the calculations, I will show you that the prescribed dose is a healthy 27, and the delivered dose is 26.9. Very good, right? So the machine is going, we have a higher dose, things should be perfect, things are going all right. Is this a good CRRT order? It uses anticoagulation, that's good. The modality is good, the prescribed dose is good, the delivered dose is good, appears to be a good prescription, right? But the nurse is upset. She tells you that the filter clotted 6 hours after starting the treatment and has clotted for the second time in the last 12 hours. So that's more downtime, so your delivered dose is again going down, but this time not going down because of the dilution, but because of something else. She's spending the time changing the filter, she's unhappy, and your delivered dose has diminished, and that is the filtration fraction. That's probably happening, right? Because you're putting the replacement fluid post-filter, and if you calculate the filtration fraction, you come up with, you can find it on the screen, good machines have it, so you can again find it in there, the filtration fraction. Make sure that the nurse had entered the hematocrit that day, because you need it for make the calculation. But if you have it, you'll find that the filtration fraction is 31%. So that may be why this filter is clotting, because the filtration fraction is too high. So what are you going to do? Because you want to keep it less than 25%. Well, how do I decrease the filtration fraction? I can increase the flow rate. I can change the replacement to pre-filter and make a better balance between the dilution and the filtration fraction and have better results. In summary, I think that in order to prescribe and to manage continuous renal replacement therapies, one needs to know exactly what is going on. This is a team game. This is not you going in, writing, and leaving. It's a team game. You need to talk with people, you need to touch the machine, need to learn where the on-off is, and also where the alarm reset button is, but also you need to know how it works, and you need to adjust the treatment moment to moment. right? Because the management of the patient with critical ill is not a once-a-day thing, but actually you need to be there and adjust the management of the fluid and the composition of the fluids as you go. Thank you very much.